1-year-old female who's a housewife came to us with complaining of having cervico upper dorsal region pain since last 1 year. And then it is gradually increasing. And since 6 months, she is also having tingling, burning and numbness over the chest. The pain is not radiating into hands. It is dull, aching, continuous, non-episodic, no diurnal variations. Now recently when she has come, she is also complaining of weakness in her right leg with slipping of chappals and not having any bowel or bladder involvement. There is no significant past illnesses to her, but her family history says that her cousin had treated for tuberculosis a few years back. Okay. So on her examination, higher mental functions and cranial nerves were normal. Only there was some increased tone in her right ankle. Power was grade 5/5 in all limbs except for subtle weakness in the right knee, ankle and external hallucis, which was grade +4/5. Jerks were not exaggerated, but plantar in the right was extensor and left was mute. She was able to walk comfortably and there was no limp. There was decreased sensations to touch and temperature below D6 dermatome and no other bowel, bladder or any other symptoms were there. So we got her scan done. This is MRI, T1 weight and T2 weighted. This is the contrast. So what the house think the diagnosis can be. Any opinion on the diagnosis?
Yeah, we'll take the call.
Yeah, there seems to be like anterior, again middle and posterior column involvement. But unlike the other case, the first case that was shown,
Yeah, there was port spine case, yeah.
That was port spine.
Yeah.
But here there is no collection.
Here there is no collection.
And there is uniform expansion. There is expansion of the pedicle as well.
Yeah.
Posterior elements, anterior elements.
Yeah,
So
the
likely
lesion
to
is
be-
extending from the left half of the 3, 4 and 5 bodies.
Correct.
And extending posteriorly to involve the lateral element also on one level.
Correct. So radiologically likely to be a neoplastic pathology.
Yeah.
No, not
And
an infective pathology.
What about the history of exposure to tuberculosis?
Sorry, I didn't listen to that.
The-
I missed that part.
Her cousin history of tuberculosis, which was treated for few years back.
I mean, we are all exposed.
Yeah.
Okay, if that is
So that makes
5 years back,
yeah.
everybody is.
So
dealing
MRI,
with this.
MRI is not favoring tuberculosis
Okay.
in view of history arrangements. Not favoring.
No, here we have to know whether this is something you caught it at a stage when it has already healed. Then that is a possibility. Like 3 vertebrae, typically when they heal post-tuberculosis, this heals like this. So that is a possibility. Might be a partially or maybe treated.
Okay. So we also did a CT scan. This was the CT scan images.
Yeah, not unlikely to be.
Yeah, na, CT is there.
Okay. So what would be the next line of management?
Yeah. Ajay, what do you think? Deva.
Considering that the patient is still got about 4 plus by 5 power,
Yeah, but it
we'd
is
like to do
recently started to deteriorate.
we'd like to get CT guided biopsy if possible.
Yeah. So any other option?
Yeah, that's a good option, but yes, ultimately.
Yeah,
I
actually
guess
the
I will-
lesion is quite superficially situated.
Correct.
So we got a true cut biopsy USG guided. It was possible. So we got a good amount of tissue on USG guided biopsy. So biopsy report has arrived and it is suggestive of giant cell tumor.
Correct, yeah.
Now, what is the line of treatment next?
Yes, Rajesh, what is the line of treatment for giant cell tumor of the spine?
We can go thoracotomy anterior approach and remove all the things and put the cage or the bone graft, and we can do a decompressive laminectomy or remove all the involved bone elements.
So, is thoracotomy a good and comfortable option at this high level? Only
Yeah,
thoracotomy and anterior fixation will do, or we have to go for posterior fixation also?
It has to be done. Posterior fixation
Posterior
has to be done.
Means both anterior and posterior has
But
to be done.
difficult thoracotomy because it's little higher up.
Yeah.
Even the
Because
of the aorta will comes
the
there.
higher screw, you have to go up to D2.
Yeah.
You see this image. No, but we have to go up to D7 level. Go behind and yeah, we have to fix posteriorly. That is, I think everyone agrees that we have to fix posteriorly. The question is anterior plus posterior approach or only posterior approach
Because
will do?
this is all near manubrium sternum, so upper part of sternum, if you remove open,
Anterior has to be
fix it, decompress anteriorly, and put a cage there, and then go
So
behind.
it is
and
going
posteriorly.
below the manubrium. It's up to
hemisternotomy.
We can
no,
just-
but it will be difficult to go from anteriorly. because all the mediastinal structure will be right there. Up to D2 we can go, but it is going up to D5, 6. For fixation, we have to go up to D6. D5 we have to maybe excise because it is also involved.
Posterolateral approach with a costotransversectomy, and we can excise the tumor and at the same time we can do a posterior fixation.
Yeah. So, sir, what you would suggest?
Yeah, now in today's time, I would say it's quite possible and feasible to go from posterior approach only and resect everything and do one stage anterior as well posterior reconstruction. But I have done many such cases through thoracotomy also. And when you do through thoracotomy, you have to mobilize whole of the scapula, retract it to the other side, and the proximal most place in the body where you can put in screw easily is up to the D2 level.
Yes.
Beyond that, you start getting the subclavian vein vessel. So that becomes a bit tricky, but up till D2 level, you can easily put in.
Sir,
So in case you want to go that way, but best is possible.
I also discussed the case with a radio-oncologist. He says the giant cell tumor, they respond
Yes,
good
drug.
to-
So, before surgery, since we are only talking about the drug, in today's time, we have drug available. So
drugs.
I
I'm
think
not aware. I'm not aware. Radiotherapy, he said, it will help in controlling the
yes,
disease.
That's true, but some drug, I think Manoj probably you will know. We have put in couple of patients and it responds very well.
What about denosumab?
No,
It's
no,
already the compression there from the anterior side. Still you want
No,
to,
anterior and posterior both is there. Compression is both.
it's already the pinching effect is there on the cord.
Yeah.
But still you want to go with the drug to wait.
No, the option is there. See, if
Yeah,
the
we are
drug
only
or
talking
that
about
thing is there,
options,
can I avoid a thoracotomy? I can go posterior fixation and just start giving drug or radiotherapy if the option is available. Is that option worth considering or not?
Yeah,
No, because the
posterior
patient still, we cannot counsel the patient because he's already having the neurological deficits.
Yeah.
And he doesn't want to, one more to progress, either to progress or remain static in that stage.
So we are going to operate.
Yeah.
So now operation, if I can go ahead only with the posterior operation, do the fixation, do the debulking, and then go for radio or chemotherapy. One option is this. Another option is go for posterior decompression completely, if possible, remove the anterior part also, put a graft, and then come out. And third option is go for anteriorly and posteriorly both, and then do the maximum possible resection.
should be possible to decompress, excise radically from the posterior. There's no
It's-
reason. Because
okay.
everything is contained therein.
Yeah. So we are also planning the same. Patient is right now not consented for the surgery. So if she agrees, we are planning for posterior decompression and stabilization. Yeah. Thank you.
Thank you very much. So in next SpineCon, we already have one case
Important
registered to be
message here
discussed.
is to understand whether this is tuberculosis
Yeah,
or this
one
is
was this,
malignant
yeah.
disease. Because the treatment is radically different.
Yeah.
And
Yeah.
radiological features are very typical.